It's a strange thing. What happens after we die? Our bodies, once so full of life and secrets, become quiet. But even in that quiet, they still have stories to tell. Big stories, important stories. Stories about why we get sick, how treatments work or don't work, and sometimes even why we die. Think about it. We spend our lives trying to understand the human body. We use scans, blood tests, powerful microscopes. We try to guess what's going on inside. But there's one way to know for sure. One way to open things up and look. That's the autopsy. It's not about ghoulish curiosity. It's about knowledge. It's about learning. Did you know that in some older studies, up to 10% of major clinical diagnoses were missed before death? That's a huge number. That's 10 out of every 100 people. Think of all the wrong treatments, all the chances missed. Or consider this sudden infant death syndrome SIDS was a mystery for so long. Its autopsies helped us understand it. They helped doctors look for patterns, for tiny changes, for clues nobody expected. And what about those strange, rare diseases? The ones doctors scratch their heads about. The ones with symptoms that don't quite fit. Sometimes an autopsy is the only way to really put the pieces together. It's like the ultimate medical review, the final exam for a lifetime of health or illness. We've been looking at what happens inside us after death for centuries. From ancient Egyptian mummification, which involved incredibly detailed removal and preservation of organs, to the structured anatomical studies of the Renaissance, people have always sought to understand the body's inner workings. Andreas Vesalius, in the 16th century, changed medicine with his book, De Humani Corporis Fabrica, based on his dissections. He corrected centuries of anatomical errors made by Galen, errors that had been accepted without question. And those corrections, they came from really looking inside the human body. Later, in the 19th and 20th centuries, autopsies became a cornerstone of medical education and research. Rudolf Virchow, a German physician often called the father of modern pathology, insisted on autopsies to link clinical symptoms to tissue damage. He understood that you needed to see the disease in the organs to truly understand what it did to the living person. His work laid the groundwork for how we study disease today. So, when medical journals talk about autopsy findings, they're not just reporting on a dead body. They're telling a story about life, about disease, about how close we came to understanding, and sometimes how far off we were. They're talking about the silent teachers who, in their final act, give us the most profound lessons. These detailed accounts from medical journals give us a window into these lessons. They show us how much we've learned and how much there still is to know. Number 10, how often do we get it wrong? It's a humbling thought, but doctors aren't perfect. No one is. And sometimes what we think is happening inside a living patient turns out to be something else entirely. This is where autopsies really shine a bright, sometimes harsh light. They act as the ultimate quality control. For decades, medical journals have published studies comparing clinical diagnoses, what doctors thought was wrong, with autopsy findings, what was actually wrong. The numbers are often eye-opening. Take a study published in the Journal of the American Medical Association back in the late 1980s. It looked at a series of autopsies performed at a major teaching hospital. The researchers found that in a significant number of cases, serious diagnostic errors were only discovered after death. These weren't just minor things, these were conditions that, if caught, might have changed treatment or even saved a life. We're talking about missed cancers, undiagnosed infections like pneumonia, or even complicated heart conditions. A similar review published in the Archives of Pathology and Laboratory Medicine in the early 2000s confirmed this trend, showing that major diagnostic discrepancies were still present in about 10 to 15% of cases. One common area of discrepancy involves infections. It's hard to diagnose deep-seated infections in a living person. Sometimes symptoms are vague or they mimic other conditions. A review from the American Journal of Clinical Pathology discussed cases where lethal infections, like fungal sepsis, were only identified post-mortem. The patient might have been treated for something else, or the infection was simply too aggressive and spread too quickly to be properly identified clinically. This isn't about blaming doctors, it's about acknowledging the limits of current diagnostic tools and the complexity of human illness. Another fascinating area is cardiovascular disease. It's a leading cause of death, and we have many ways to diagnose it. But sometimes a fatal heart attack or a silent rupture of an aortic aneurysm isn't suspected until the autopsy. A long-running study from the Mayo Clinic, often cited in medical education, detailed how even with advanced imaging and lab tests, some severe cardiac pathologies are simply missed. For instance, a small calcified plaque in a coronary artery might not seem significant on an angiogram, but an autopsy can show it was the direct cause of a fatal clot. Or a subacute myocarditis, an inflammation of the heart muscle, can present with flu-like symptoms, making it incredibly difficult to diagnose before death. These findings aren't meant to scare anyone. They're meant to inform. They drive improvements in medical education. They push for better diagnostic tests. They remind us that medicine is an ongoing learning process. When a journal details a discrepancy, it's not just reporting a fact, it's prompting a discussion among clinicians. How could we have known? What did we miss? What signs should we look for next time? The insights from these autopsy correlation studies have led to new clinical guidelines. For example, understanding missed pulmonary emboli blood clots in the lungs prompted more aggressive screening in at-risk patients. When autopsies repeatedly showed that deep vein thrombosis DVT and subsequent pulmonary embolism PE were missed causes of death, clinicians started paying more attention to patients who were immobile, had surgery, or had a history of clotting. This direct feedback loop from the autopsy table back to patient care is invaluable. It's also crucial for understanding rare diseases. If a disease is rare, clinicians might not recognize its presentation. An autopsy can provide the definitive diagnosis, adding to the body of knowledge for that condition. A review in the Journal of Forensic Sciences highlighted several cases where rare genetic disorders or metabolic conditions previously undiagnosed were definitively identified through detailed post-mortem examination. These cases then serve as learning points for future medical professionals. And it's not just about what caused death. Autopsies also reveal the extent of disease. A patient might die with advanced cancer, but an autopsy can show the full spread of the disease, how it affected other organs, and why a particular treatment failed. This information is critical for oncology research. If a new chemotherapy drug is being tested and a patient dies, an autopsy can show if the drug effectively targeted the tumor or if the tumor had developed resistance in ways not predicted. So, how often do we get it wrong? More often than we'd like to admit, but each time we find a discrepancy, we learn. We get a little bit better at understanding the incredibly complex machine that is the human body. And that learning born from looking at the silent dead helps the living. But what if we don't know the full story of what was missed even after an autopsy? How many subtle, undiagnosed conditions contribute to a person's vulnerability without being the direct cause of death? Can we ever truly eliminate diagnostic error? Or is it an inherent part of practicing medicine? And what about the conditions that are so rare, even an autopsy might only offer partial answers? Number 9, what does the heart really tell us after death? The heart, everyone says, is the engine of life. And when that engine stops, it leaves behind a lot of clues. Autopsy findings, detailed in countless medical journals, have drastically shaped our understanding of cardiovascular disease. This isn't just about heart attacks, it's about everything that can go wrong with that vital pump. Think about atherosclerosis. That's the hardening and narrowing of arteries. We know a lot about it now: cholesterol, plaque buildup, inflammation. But much of that detailed understanding came from looking at thousands of hearts after death. Early pathologists like William Osler in the late 19th and early 20th centuries meticulously described atherosclerotic plaques. Well, his observations, published in medical texts and journal correspondences, were foundational. He linked these plaques to heart disease symptoms and sudden death. Later in the 1950s and 60s, large epidemiological studies like the Framingham Heart Study started to connect risk factors in living people to the disease, but autopsies still provided the definitive proof of the extent and severity of the disease. A study from the American Heart Journal in 1965, for instance, correlated antemortem blood pressure readings with the degree of arterial stiffness and plaque formation, found at autopsy, offering solid evidence for the link. And then there are heart attacks or myocardial infarctions. For a long time, doctors understood the symptoms, but not always the precise mechanism. Autopsies help confirm that most heart attacks are caused by a blood clot, a thrombus, forming on a ruptured atherosclerotic plaque in a coronary artery, blocking blood flow to part of the heart muscle. In the 1970s, researchers like Drs. James T. Willerson and Frederick J. Schoen, whose work has been published extensively in journals like Circulation, provided detailed pathological descriptions of the stages of myocardial infarction, from early cell death to full scar formation. These findings were critical for developing treatments like thrombolytic drugs, which aim to dissolve these clots. If you didn't know exactly what you were trying to dissolve, how could you develop an effective drug? Sudden cardiac death is another major area illuminated by autopsies. Imagine a seemingly healthy person just collapsing. Why? Autopsies have revealed a surprising array of causes. Hypertrophic cardiomyopathy, a genetic condition where the heart muscle becomes abnormally thick, is a common culprit, especially in young athletes. The detailed anatomical descriptions of this condition, including its characteristic disarray of heart muscle cells, were first extensively reported in journals like the New England Journal of Medicine in the 1980s. These reports link the specific heart abnormalities to the risk of fatal arrhythmias. Another cause is arrhythmogenic, right? Ventricular cardiomyopathy RVC, where normal heart muscle is replaced by fat and fibrous tissue, leading to electrical instability. Researchers in Europe, particularly in Italy, contributed heavily to our understanding of RVC through extensive autopsy series reported in journals such as Heart Rhythm. Their work identified specific pathological features like the fibrofatty replacement of the right ventricle, which are now diagnostic criteria. Sometimes autopsies reveal unusual infections affecting the heart, like myocarditis and inflammation of the heart muscle. Viral infections are common causes. Post-mortem examinations have shown how these viruses directly damage heart cells, sometimes leading to sudden heart failure or arrhythmias. Studies reported in the Journal of the American College of Cardiology have shown different patterns of viral myocarditis, helping clinicians better understand the prognosis and potential treatments. And it's not just about structural problems. Autopsies can shed light on the effects of other diseases on the heart. Diabetes, for instance, can lead to a specific type of heart muscle damage, diabetic cardiomyopathy, even without significant coronary artery disease. Pathologists performing autopsies can identify the subtle changes in heart muscle cells and the small blood vessels that characterize this condition, as detailed in reports in cardiovascular pathology. These findings underscore the systemic nature of diseases and how they affect multiple organs. Even medical treatments can have effects on the heart that are only fully appreciated post-mortem. Certain chemotherapy drugs can be toxic to the heart. Autopsies of cancer patients who died with cardiac complications have provided critical data on the patterns of drug-induced cardiotoxicity, helping oncologists adjust treatment protocols and monitor patients more closely. Publications in the Journal of Clinical Oncology have often included sections discussing these autopsy findings. The Heart in Death continues to beat out lessons for the living. It teaches us about the progression of disease, the silent killers, and the subtle ways our bodies fail. Without this detailed look inside, much of our knowledge of cardiology would be based on educated guesses. But how do we detect these subtle genetic predispositions for heart conditions in living individuals before it's too late? Are there specific biomarkers that could warn us of impending sudden cardiac death, even if the heart looks outwardly normal? And what about the environmental factors that subtly erode cardiac health over decades? Can autopsies truly pinpoint their cumulative impact? Number 8, what secrets does the brain keep after death? The brain. It's the most complex organ, the seat of our thoughts, memories, and consciousness. When it stops working, the brain still holds immense secrets. Autopsies, especially neuropathological examinations, have been crucial for understanding devastating neurological diseases. Alzheimer's disease is a prime example. For years, people knew something caused memory loss and cognitive decline in older age. But it was Alois Alzheimer, a German psychiatrist and neuropathologist, who in 1906 first described the distinct pathological features in the brain of a patient who had suffered from severe memory loss and behavioral changes. He identified the characteristic amyloid plaques and neurofibrillary tangles, which are now considered the hallmarks of Alzheimer's. His original observations, published in German medical journals, were meticulous. Subsequent neuropathological studies over decades confirmed these findings and elaborated on their distribution and composition, published widely in journals like Brain and Acta Neuropathologica. These autopsies proved that Alzheimer's was a specific disease with distinct physical changes in the brain, not just old age senility. Parkinson's disease, too, owes much of its understanding to autopsies. While James Parkinson first described the clinical symptoms in 1817, it was not until the early 20th century that the specific neuropathological lesion was identified. Konstantin Tretiakov, a Russian-French neuropathologist, observed in 1919 the presence of Lewy bodies abnormal protein aggregates in the substantia nigra, a region of the brain involved in motor control in the brains of Parkinson's patients. This finding, published in a relatively obscure thesis, was later confirmed and popularized by others, leading to our current understanding that Lewy bodies are a key pathological feature of Parkinson's. Autopsies continue to reveal variations in Lewy body pathology, leading to the concept of Lewy body dementia, where these bodies are more widespread in the brain, impacting cognition more profoundly. Researchers frequently report on these patterns in journals like Movement Disorders. Stroke is another area where autopsies have provided critical insights. We know strokes are caused by interrupted blood flow to the brain, either from a clot ischemic stroke or bleeding hemorrhagic stroke. While imaging techniques like MRI and CT scans are excellent for diagnosing strokes in living patients, autopsies offer a microscopic view of the damage. They show the specific regions of neuronal death, the changes in brain tissue over time after a stroke, and the extent of any pre-existing cerebrovascular disease that contributed to the event. A major study in the Journal of Cerebrovascular Disease in the 1990s used autopsy findings to detail the specific microvascular changes associated with chronic hypertension, demonstrating how years of high blood pressure silently damage the brain's small vessels, increasing stroke risk. Traumatic brain injury (TBI) is also a field deeply informed by postmortem examination. From single acute injuries to repeated concussions, autopsies reveal the physical damage. Researchers looking at the brains of athletes, particularly boxers and football players after their deaths, found a distinct neurodegenerative disease called chronic traumatic encephalopathy (CTE. Dr. Bennett Omalu's initial findings in the brain of former NFL player Mike Webster, published in Neurosurgery in 2005, showed specific patterns of tau protein accumulation, distinct from Alzheimer's, directly linked to repetitive head trauma. This discovery, confirmed by many subsequent autopsy studies published in JAMA Neurology and other journals, transformed our understanding of sports-related brain injury and its long-term consequences. Even seemingly unrelated conditions can affect the brain. Autopsies of patients with severe infections, for example, might reveal widespread inflammation in the brain or even microabscesses that were not suspected clinically. A series of cases presented in the Journal of Infectious Diseases detailed how certain bacterial and viral infections could lead to significant neurological damage, even in patients who didn't exhibit overt neurological symptoms before death. These findings highlight the brain's vulnerability to systemic illness, and sometimes autopsies reveal congenital malformations or developmental disorders of the brain that were previously unknown or poorly understood. In pediatric pathology, detailed examinations of infant brains have uncovered subtle abnormalities in brain development that contribute to conditions like epilepsy or developmental delay, as reported in journals focusing on neuropathology. These insights help geneticists and pediatricians understand the underlying causes of complex neurological conditions in children. The brain, even after life has left it, continues its complex work of teaching. Each sectioned piece, each stained slide, adds to our collective knowledge about the diseases that steal our minds and abilities. It's a profound exchange where the ultimate silence yields the loudest truths about our most intricate organ. But how do we fully map the complex interplay between different pathological changes in the brain, especially when multiple conditions might be present simultaneously? Can we ever truly understand the subjective experience of a disease like Alzheimer's from just looking at brain tissue? And what about the subtle functional changes that occur long before any visible pathology appears? Can autopsies ever really capture those? Number 7, how do diseases spread inside us? The story of metastasis, cancer. It's a word that strikes fear, and one of the most terrifying aspects of cancer is metastasis, its ability to spread from one part of the body to another. Autopsies have been absolutely critical in understanding how cancer moves, where it goes, and why it sometimes seems to pop up in unexpected places. These detailed post-mortem examinations provide a complete picture of cancer's journey through the body, a picture often impossible to get from living patients. Early pathologists, even before the concept of metastasis was fully understood, made observations about tumors appearing in different organs. Giovanni Battista Morgagni, an 18th century Italian anatomist, described how different diseases affected various organs, and in his famous book, De Sedibus et Causis Morborum per Anatomen Indagatis, he detailed observations of what we now recognize as metastatic disease, long before the term existed. Rudolf Virchow, in the 19th century, also observed tumor cells in blood vessels and lymph nodes, beginning to hypothesize about their spread. By the 20th century, with advances in microscopy and cellular biology, autopsies became the primary tool to map metastatic patterns. A seminal series of studies in the 1960s and 70s, many published in the Journal of Clinical Oncology and Cancer Research, documented the typical sites of metastasis for different types of primary cancers. For example, lung cancer often spreads to the brain, liver, and bones. Breast cancer commonly metastasizes to the bones, lungs, liver, and brain. Colorectal cancer frequently spreads to the liver and lungs. These patterns, observed consistently across thousands of autopsies, allowed oncologists to anticipate where cancer might spread and to develop targeted screening protocols. One particularly insightful area involves understanding why certain cancers favor specific organs. This concept, sometimes called the seed and soil hypothesis, suggests that cancer cells, the seeds, only grow well in specific microenvironments, the soil of certain organs. Autopsies provide direct evidence for this. For instance, detailed pathological examination might show that while a patient had widespread cancer, certain organs, like the spleen or thyroid, remained largely spared. The researchers could then investigate the molecular differences in these resistant organs, as compared to those heavily infiltrated, a topic often explored in journals like Oncogene. Autopsies also reveal the microscopic pathways of spread. They show tumor cells invading blood vessels, hematogenous spread, or lymphatic vessels, lymphatic spread. They illustrate direct invasion into adjacent tissues. A study from the Annals of Oncology in the late 1990s, for example, showed how pancreatic cancer, known for its aggressive nature, often spreads early through perineural invasion along the nerves, a pathway difficult to detect in living patients but evident on careful post-mortem histology. This understanding helped explain the characteristic pain often associated with pancreatic cancer and suggested new therapeutic targets. Sometimes, autopsies uncover occult metastases, small deposits of cancer that were never detected clinically. A patient might die from complications of their primary cancer, and an autopsy reveals tiny, previously unknown metastases in critical organs, subtly contributing to organ failure. These findings, often reported in journals like Human Pathology, highlight the limitations of even advanced imaging in detecting all cancer spread, especially at a microscopic level. Moreover, autopsies are critical for evaluating the effectiveness of cancer treatments. If a patient dies after a new chemotherapy regimen, an autopsy can determine if the drug effectively reduced tumor burden, if resistant clones emerged, or if the drug caused unexpected toxicities to other organs. A study in the Journal of the National Cancer Institute from the 2000s, for instance, used autopsy data to assess the response of metastatic melanoma to novel immunotherapies, showing which organs responded better to treatment and where the disease persisted. Another important aspect is understanding the cause of death in cancer patients. While it might seem obvious that cancer caused death, autopsies frequently reveal that it's not always the direct tumor burden. Patients often die from complications, overwhelming infection due to a weakened immune system, massive pulmonary embolism, or organ failure from metastases that were not the primary focus of treatment. A review published in Cancer illustrated that while cancer was the underlying cause, the immediate cause of death was often a treatable complication if identified in time. This knowledge helps clinicians provide better supportive care. The detailed, whole-body perspective offered by an autopsy on cancer's journey is simply unmatched. It provides a roadmap of disease progression, offering invaluable insights for prevention, early detection, and the development of new therapies. Without this unflinching look at cancer's final destructive path, our understanding would be far less complete. But why do some individuals with widespread metastasis live for years, while others succumb quickly with less tumor burden? Are there genetic or environmental factors that determine the soil receptiveness of different organs? And how can we develop treatments that not only target the primary tumor, but also effectively block all the microscopic pathways of metastases, which autopsies reveal with such stark clarity? Number 6, what kills us when we're healthy? Understanding sudden death. Sudden death, especially in apparently healthy individuals, is one of the most perplexing and tragic events. It leaves families with unanswered questions and communities grappling with loss. The medical journals frequently feature extensive studies on sudden death, and autopsies are the cornerstone of this understanding. Without them, we would simply have speculation. The primary focus for pathologists investigating sudden death is the heart. We talked about sudden cardiac death earlier, but it's worth revisiting in this context. Often the deceased had no known heart problems. Autopsies reveal various culprits. A coronary artery disease, even when not causing symptoms, can silently progress. A small plaque might suddenly rupture, causing a fatal clot. Dr. Renu Vermani, a prominent cardiac pathologist, has published extensively in journals like Circulation and the Journal of the American College of Cardiology, detailing the morphology of plaques that lead to sudden death, even in seemingly healthy individuals. Her work has shown that it's often not the largest plaques that rupture, but those with specific vulnerable characteristics like a thin, fibrous cap. Beyond atherosclerosis, genetic heart conditions are major players in sudden death, especially in young people. Hypertrophic cardiomyopathy (HCM) and arrhythmogenic right ventricular cardiomyopathy (RIVC) are common examples. The pioneering work on these conditions, linking specific genetic mutations to structural heart abnormalities and then to sudden death, comes largely from autopsy series. For instance, Dr. Barry J. Marin's extensive research, often appearing in Circulation, built a comprehensive profile of HCM through decades of studying autopsy cases, leading to better screening protocols for athletes. Long QT syndrome and Brugada syndrome, which are primary electrical disorders of the heart with often normal-appearing hearts at autopsy, are increasingly diagnosed posthumously through advanced genetic testing of tissue samples taken during autopsy. These findings, published in journals like Heart Rhythm, allow for cascade screening of family members, potentially saving lives. But sudden death isn't always about the heart. Sometimes it's a silent brain hemorrhage, an undiagnosed aneurysm, a weak spot in a blood vessel in the brain, can rupture without warning. Autopsies confirm these catastrophic events, identifying the location and size of the hemorrhage. A large multi-center study on sudden non-traumatic intracranial hemorrhage, published in Stroke in the late 1990s, utilized autopsy data to understand risk factors and the typical anatomical locations of these fatal bleeds. Pulmonary embolism, a blood clot in the lungs, is another silent killer. It can arise from a deep vein thrombosis DVT in the legs, and if it travels to the lungs, it can be immediately fatal. Many individuals who die suddenly from PE have no prior symptoms. Autopsies, often detailed in forensic pathology journals like the Journal of Forensic Sciences, frequently uncover these clots, sometimes massive, sometimes smaller, but numerous, leading to acute right heart failure. The recognition of PE as a common cause of sudden death has spurred awareness campaigns and preventative measures, especially in hospital settings for postoperative or immobile patients. Infections, too, can cause sudden death. Overwhelming sepsis, a body-wide inflammatory response to infection, can lead to rapid organ failure. While often diagnosed clinically, sometimes the infection progresses so rapidly or is so subtle in its initial presentation that death occurs before a definitive diagnosis. Autopsies can identify the source of the infection, such as a ruptured appendix, a fulminant pneumonia, or a bacterial endocarditis that was not suspected. A series of cases in the American Journal of Clinical Pathology detailed instances where unexpected, rapidly fatal infections were the sole cause of sudden death. Even drug overdoses, both accidental and intentional, fall under the umbrella of sudden death investigations. Forensic autopsies, combined with toxicology reports on postmortem samples, identify the substances and their concentrations that led to death. The opioid crisis, for example, has seen a massive increase in sudden death autopsies, with findings published by public health agencies and in journals like Forensic Science International charting the specific drugs involved and their lethal doses. This data is critical for public health responses. The value of these post-mortem examinations in understanding sudden death extends beyond just identifying a cause. They provide a vital epidemiological tool, helping to track trends in diseases, identify new health threats, and improve public health strategies. Every unexplained sudden death is an opportunity to learn, to add another piece to the vast puzzle of human vulnerability. But how do we identify those at highest risk for silent killers like undiagnosed genetic heart conditions or occult aneurysms without resorting to overly invasive or expensive screening for everyone? What are the subtle, pre-mortem biological markers that could foretell sudden death even when no symptoms are present? And how do we account for deaths where, even after a thorough autopsy, no definitive cause can be found? What remains truly unknown about these tragic endings? Number 5, when treatments go wrong, the iatrogenic factor. Medicine is about healing, but sometimes in the pursuit of healing, things go wrong. These are called iatrogenic complications, conditions, or deaths caused by medical examination or treatment. It's a difficult topic, one not always openly discussed, but autopsies have played a crucial role in bringing these issues to light, helping medicine learn from its mistakes and improve patient safety. Medical journals frequently report on these findings, not to assign blame, but to highlight systemic issues and prevent future harm. One classic example is medication errors. A patient might receive the wrong dose of a drug, or a drug they are allergic to. While clinicians strive to prevent this, fatal errors do occur. Autopsies, combined with careful review of medical records and toxicology, can definitively link a medication overdose or adverse reaction to the cause of death. Early studies in the Journal of the American Medical Association in the 1990s, for instance, documented the prevalence of medication-related deaths identified at autopsy, often revealing that the errors were multifaceted, involving prescribing, dispensing, or administration issues. Surgical complications are another significant area. While most surgeries are successful, complications like unforeseen bleeding, infection at the surgical site, or injury to adjacent organs can occur. Autopsies provide undeniable evidence of these complications. For instance, a patient dying unexpectedly after abdominal surgery might reveal, upon autopsy, an anastomotic leak where two parts of the intestine sewn together have separated, or a missed injury to a major blood vessel. These findings, often published in surgical journals like the Annals of Surgery and their Morbidity and Mortality Conferences section, drive discussions about surgical techniques, intraoperative monitoring, and postoperative care. In the early 2000s, a large study published in the British Journal of Surgery analyzed autopsy findings following surgical deaths, highlighting common patterns of error and leading to improved checklists and safety protocols. Even medical devices can cause iatrogenic harm. A pacemaker lead could fracture, or a prosthetic heart valve could malfunction. Autopsies allow for detailed examination of these devices in situ and, after removal, identifying the precise mechanical failure or biological complication like an infection around the device that led to death. Reports in journals like JACC Cardiovascular Intervention sometimes include detailed postmortem analyses of device failures, providing crucial feedback to manufacturers and regulatory bodies. Hospital-acquired infections are a persistent problem. Patients, already weakened, can contract severe infections like Clostridium difficile or methicillin-resistant Staphylococcus aureus necissa in the hospital. Autopsies often identify these infections as the primary or contributing cause of death, especially in patients who are immunocompromised. Studies in journals like Infection Control and Hospital Epidemiology frequently use autopsy data to demonstrate the burden of hospital-acquired infections and the need for stricter hygiene protocols. The post-mortem identification of a multi-drug-resistant pathogen can spur immediate action within a hospital to prevent further spread. Diagnostic procedures themselves, while usually safe, carry risks. A biopsy might inadvertently perforate an organ, or an angiogram might cause arterial damage. While rare, these complications can be fatal. Autopsies provide irrefutable evidence of such events, leading to a review of procedural techniques and training. Case reports in journals like the American Journal of Röntgenology have occasionally detailed fatal complications of interventional radiology procedures, with autopsy findings providing the definitive explanation. The importance of autopsies in identifying iatrogenic factors cannot be overstated. They provide transparency and accountability. They ensure that errors are not buried, but instead become lessons learned. This isn't about shaming. It's about systematically improving the safety and quality of patient care. The data gathered from these specific types of autopsy findings directly feeds into patient safety initiatives, development of clearer protocols, and better medical training. It reminds the medical community that even with the best intentions, the human body is incredibly complex, and interventions, no matter how carefully planned, carry inherent risks. Each finding of an iatrogenic death in a medical journal serves as a stark reminder of the continuous need for vigilance and improvement in healthcare. But how do we differentiate between an unavoidable complication of a severe illness and a preventable medical error, especially in complex cases with multiple comorbidities? What is the true incidence of iatrogenic harm, given that many cases might never reach an autopsy table? And how do we create a medical culture where these findings are openly discussed and learned from, without fear of reprisal, ensuring that the dead truly teach the living? Number 4, how can a dead body help the living breathe? Insights into respiratory disease. Our lungs are incredible. They work tirelessly, taking in air, exchanging gases, and keeping us alive. But they are also vulnerable to many diseases. Autopsies have been instrumental in understanding respiratory conditions, from common infections to chronic illnesses and rare lung pathologies. The detailed look at lung tissue after death offers a level of insight that imaging and biopsies in living patients sometimes can't match. Pneumonia, a common lung infection, is a frequent cause of death, especially in the elderly or immunocompromised. While often diagnosed and treated clinically, autopsies have revealed much about its progression and variations. Early 20th century pathologists meticulously described the different stages of lobar pneumonia, linking specific bacterial infections to patterns of inflammation and consolidation in the lung tissue. Books like William Boyd's Textbook of Pathology, a staple for medical students, contain detailed illustrations derived from countless autopsy specimens. Studies in the American Review of Respiratory Disease from the mid-20th century further classified pneumonias based on autopsy findings, helping to refine diagnostic criteria. Often, autopsies reveal unsuspected underlying conditions that made a patient more susceptible to pneumonia, such as aspiration of stomach contents, which leaves specific pathological changes in the lungs. The chronic obstructive pulmonary disease COPD, which includes emphysema and chronic bronchitis, is another condition significantly understood through post-mortem examination. Autopsies of long-term smokers provided definitive proof of the destructive effects of smoking on lung tissue, showing the enlargement of air spaces, emphysema, and thickening of bronchial walls, chronic bronchitis. Early work by pioneers like Dr. Lynn Reid, a British pathologist who, in the 1950s and 60s, published detailed anatomical studies of the bronchial tree, greatly advanced our understanding of the morphological changes in COPD, often featured in journals like Thorax. These findings, correlated with years of smoking history, provided irrefutable evidence for anti-smoking campaigns. Tuberculosis TB, a historical scourge, also yielded its secrets to the autopsy knife. Before antibiotics, TB ravaged communities, and pathologists were the ones to document its devastating spread throughout the lungs and other organs, forming characteristic granulomas and cavitation. The work of Robert Koch, who identified the TB bacillus in 1882, was supported by countless pathological observations linking the microorganism to the specific tissue damage observed in autopsies. Even today, in regions where TB is prevalent, autopsies help understand drug resistance patterns and the systemic spread of the disease, with findings reported in journals like the International Journal of Tuberculosis and Lung Disease. Pulmonary fibrosis, a scarring of the lung tissue, can be idiopathic of unknown cause or secondary to other conditions. Your autopsies have been vital in classifying different types of fibrosis, such as usual interstitial pneumonia, UIP, which is characteristic of idiopathic pulmonary fibrosis, IPF. The pathologists examine the distribution and type of scarring, the presence of specific cell types, and other microscopic features. A consensus statement published in the American Journal of Respiratory and Critical Care Medicine on the classification of interstitial lung diseases relies heavily on the distinct pathological patterns observed in lung biopsies and autopsy specimens. These findings guide diagnosis and treatment strategies for these often fatal diseases. Environmental and occupational lung diseases also benefit immensely from autopsy insights. Asbestosis, silicosis, and coworkers' pneumoconiosis are examples where specific foreign particles can be identified in lung tissue, along with the characteristic fibrotic reactions they cause. Autopsy studies, often published in journals focusing on occupational medicine or environmental health, have provided direct links between exposure to certain dusts and the development of severe lung disease, informing safety regulations and compensation claims. The identification of asbestos fibers in lung tissue decades after exposure, confirmed by autopsy, has been central to many legal and public health debates. Even viral pandemics like the 2009 H1N1 influenza or SARS-CoV-2 have seen autopsies play a critical role. During the COVID-19 pandemic, detailed autopsy findings, widely reported in journals like The Lancet and the New England Journal of Medicine, revealed the extent of lung damage, diffuse alveolar damage, microthrombi, tiny blood clots, and widespread inflammation. These findings were crucial in understanding the disease's pathology, explaining clinical symptoms, and guiding treatment approaches, particularly the use of anticoagulants and anti-inflammatory drugs. The lungs, in their silent post-mortem state, provide an invaluable atlas of respiratory diseases. They show us not just the end result, but often the journey of disease progression, helping us to breathe more freely in the future. But can we truly capture the dynamic process of respiratory failure in a static post-mortem examination? Are there subtle pre-pathological changes in lung function that autopsies cannot detect, but which significantly contribute to disease development? And what about the interplay between lung disease and other organ systems? How fully can an autopsy unravel those complex relationships? Number 3, what do we miss when we don't look? The role of autopsy in public health and epidemiology. When we talk about individual patients, autopsies are about understanding a single life's end. But when we look at autopsies on a larger scale, compiled across communities and over time, they become a powerful tool for public health and epidemiology. They reveal trends, uncover new diseases, and inform strategies that protect entire populations. Medical journals are repositories for these population-level insights. Consider infectious disease outbreaks. Throughout history, autopsies were the primary way to understand new plagues. During the Black Death in the 14th century, while the cause was unknown, rudimentary examinations described the swollen lymph nodes. In the 19th century, when cholera swept through cities, autopsies helped link the disease to specific gastrointestinal pathology. John Snow's famous work in London in 1854, linking cholera to a contaminated water pump, was later corroborated by pathological observations. More recently, during the early days of the AIDS epidemic in the 1980s, autopsies were crucial. Before the HIV virus was identified, pathologists observed a consistent pattern of unusual opportunistic infections like pneumocystis, pneumonia, and rare cancers like Kaposi's sarcoma in young men, as documented in early reports in the Morbidity and Mortality Weekly Report Manure and the New England Journal of Medicine. These consistent autopsy findings pointed to a new severe immune deficiency, driving the search for the underlying cause and eventually leading to the discovery of HIV. The same applied during the SARS epidemic in 2003 and the MERS outbreak more recently. Autopsy findings reported in journals like The Lancet Infectious Diseases provided detailed insights into the lung damage and systemic effects of these novel coronaviruses, helping to guide clinical management and public health containment strategies. During the COVID-19 pandemic, we saw a resurgence of interest in autopsies for similar reasons, with hundreds of reports in major journals detailing the widespread inflammation, blood clots, and organ damage caused by SARS-CoV-2, which shaped our understanding and response. Beyond infectious diseases, autopsies are vital for environmental health monitoring. If a community shows an unusual cluster of deaths from a particular disease, say a rare lung cancer or a kidney disorder, autopsies can help determine if there's a common environmental exposure. For example, in the mid-20th century, autopsy studies helped confirm the link between asbestos exposure and mesothelioma, a rare and aggressive cancer, and lung fibrosis. Research published in the Journal of Environmental Health Perspectives has often relied on post-mortem tissue analysis to detect the presence of environmental toxins in deceased individuals, linking specific exposures to disease patterns. Autopsies also inform accident prevention. In forensic pathology, large series of traffic accident victim autopsies published in journals like the Journal of Trauma have provided critical data on typical injury patterns. This data has directly influenced car safety design, leading to improvements in seatbelts, airbags, and vehicle crumple zones. Similarly, studies on drowning or fire-related deaths provide insights into prevention strategies. And what about maternal mortality? In developing countries and even in some developed nations, understanding why mothers die during or after childbirth is a major public health challenge. Autopsies, often part of maternal death surveillance programs, reveal the underlying causes such as postpartum hemorrhage, eclampsia, or undiagnosed infections. These findings, presented in journals like the British Journal of Obstetrics and Gynecology, guide interventions to improve maternal care and reduce preventable deaths. The decline in overall autopsy rates in many countries since the mid-20th century is a concern for public health. Less comprehensive autopsy data means fewer opportunities to detect emerging diseases, track disease trends accurately, and uncover misdiagnoses. Calls for increased autopsy rates, particularly in sentinel events or unexplained deaths, are often made in public health policy journals. Ultimately, autopsies provide a form of death surveillance that complements life surveillance monitoring disease in living populations. They offer a ground truth check on our understanding of disease and health, revealing patterns and pathologies that clinical medicine alone cannot fully capture. The lessons learned from the dead, compiled and analyzed in medical journals, literally save lives on a population scale. But if autopsy rates continue to decline, how will we reliably detect the next pandemic or the subtle effects of new environmental toxins? What critical public health insights are we already missing by not performing enough autopsies? And can we develop non-invasive post-mortem technologies that offer the same depth of insight as a traditional autopsy, ensuring these public health benefits continue? Number 2, Why did that drug not work? Autopsy's role in pharmacology and therapeutics. Developing new drugs is incredibly complex. And once a drug is on the market, understanding its real-world effects, both good and bad, is even harder. Autopsies surprisingly play a quiet but profound role in pharmacology and therapeutics, revealing why a treatment might have failed, how it affected the body, or even if it caused unexpected harm. Medical journals often feature these critical post-mortem insights. First, let's talk about drug efficacy. A patient might die despite receiving the best available treatment for a severe infection or cancer. An autopsy can provide critical clues about why the drug didn't work. For example, in cases of overwhelming bacterial sepsis, an autopsy might reveal an abscess so large and walled off that antibiotics couldn't penetrate it effectively. Or, in cancer patients, an autopsy might show that the tumor had developed widespread resistance to chemotherapy, with distinct genetic changes visible in the tumor cells, even if the primary tumor initially responded. Studies in journals like Antimicrobial Agents and Chemotherapy have detailed cases where post-mortem tissue analysis identified specific drug-resistant bacterial strains that led to treatment failure and death. Then there's drug toxicity. All drugs have side effects, but some can be severe and life-threatening. Autopsies are crucial for identifying unexpected or severe adverse drug reactions. A drug might cause liver damage, kidney failure, or damage to the heart muscle. If a patient dies with symptoms suggestive of drug toxicity, an autopsy can definitively confirm the damage to specific organs. For example, older chemotherapy drugs were known for cardiotoxicity. Autopsies of patients who died from heart failure after such treatments helped characterize the specific type of myocardial damage, as reported in journals like the Journal of Cancer Research and Clinical Oncology. This information helped guide safer dosing and the development of less cardiotoxic alternatives. Consider new medications too. In clinical trials, researchers follow patients closely, but rare severe side effects might only become apparent after a drug has been used by a larger population. When such a rare adverse event leads to death, an autopsy can be vital for linking the drug to the specific pathology. For example, some anti-inflammatory drugs have been linked to an increased risk of cardiovascular events. Autopsies in deceased patients who were on these drugs and died from heart attacks provided pathological evidence of vascular damage or increased clot formation, contributing to stronger warnings on drug labels and refined prescribing guidelines, as seen in publications from the FDA and journals like Circulation. Autopsies also help in understanding the effects of chronic drug use. Long-term use of certain medications, even seemingly benign ones, can lead to subtle but significant changes in organs. For instance, chronic use of certain painkillers can cause kidney damage, or long-term steroid use can lead to bone thinning and adrenal gland atrophy. While some of these can be monitored clinically, the full extent of the damage is often only truly appreciated at autopsy, with detailed reports in journals of pathology and toxicology. Toxicology plays a huge role here. In cases of suspected drug overdose, either accidental or intentional, forensic autopsies are combined with post-mortem toxicology testing. Samples of blood, urine, and tissues are analyzed to identify the specific drugs present and their concentrations. This provides definitive proof of a lethal drug level. The data from these cases, often published in Forensic Science International or the Journal of Analytical Toxicology, helps establish lethal doses for various substances, informing emergency medicine and public health. For instance, the ongoing opioid crisis relies heavily on forensic autopsy and toxicology data to track the types of opioids causing deaths and their potencies. Furthermore, autopsies can uncover drug interactions that led to an adverse event. If a patient was on multiple medications, identifying the precise contribution of each drug to a fatal outcome can be challenging. An autopsy, by revealing specific organ damage or metabolic changes, can sometimes differentiate between the effects of different drugs or identify an exacerbated toxicity due to an interaction. This detailed understanding contributes to safer prescribing practices. The dead continue to teach us about the very tools we use to extend life. Autopsies provide the ultimate post-marketing surveillance for drugs, offering an unvarnished look at how medicines interact with the complex human body, both for good and for ill. This knowledge is essential for improving pharmaceutical safety and effectiveness. But how do we effectively track and act upon subtle drug-related findings from autopsies, especially when the autopsy rate is low and reporting can be inconsistent? Are there specific biomarkers that could reliably predict individual susceptibility to severe adverse drug reactions before a drug is even prescribed. And what about the long-term cumulative effects of polypharmacy, taking multiple drugs that might be too complex for any single autopsy to fully unravel? Number one, can we really know everything? The unanswered questions. After all these discussions, all the learning, all the incredible insights autopsies have given us, it's important to acknowledge something fundamental: we can't know everything. Even after the most meticulous post-mortem examination, some questions remain unanswered. Some mysteries persist. The detailed reports in medical journals, while packed with facts, often end with discussions of limitations and avenues for future research, hinting at the vastness of what we still don't comprehend. One big unknown is the precise mechanism of death in some cases. We might identify a heart condition or a brain hemorrhage, but the exact cascade of cellular and molecular events that tip the body from life to death can be elusive. For example, in sudden cardiac death, we often find evidence of an electrical instability, but the trigger for that fatal arrhythmia, the exact moment and mechanism, might not be discernible from static tissue. A review in the Journal of the American College of Cardiology on unexplained sudden death often concludes with the need for more advanced genetic and molecular studies to fully understand these triggers. And what about functional diseases that leave no structural trace? Some conditions, like certain types of severe pain syndromes or psychiatric illnesses, are devastating in life but leave no visible changes in the body or brain at autopsy. We see the effects of these conditions on a person's life, but the underlying physical pathology often remains a mystery. While advanced neuropathology can sometimes identify subtle protein aggregates or neurochemical imbalances, many functional disorders remain invisible to the naked eye or even the most powerful microscope post-mortem. The journal Translational Psychiatry often discusses the challenges of correlating structural brain changes with complex mental health conditions. Then there's the issue of the missing link. We might identify multiple pathologies in an autopsy: a mild heart condition, some early kidney disease, and perhaps a chronic infection. But which one was the primary cause of death, or was it a complex interplay of all of them? Pinpointing the single cause can be difficult, and sometimes a physician will list multi-organ failure as the cause, acknowledging the complexity. A review in the Journal of Gerontology on causes of death in the very elderly often highlights this challenge, noting that multiple comorbidities almost always contribute, making a single definitive cause elusive. The role of environmental factors and long-term exposures also presents challenges. An autopsy might reveal widespread lung damage, but connecting that damage definitively to decades of exposure to subtle air pollutants or to a specific chemical exposure from years ago is incredibly difficult. While we can identify asbestos fibers, quantifying the impact of diffuse, low-level environmental stressors on long-term health outcomes and ultimate cause of death remains a frontier in environmental pathology, a topic often explored in journals like Environmental Health Perspectives. And what about the cutting edge of science? As our understanding of genetics and proteomics advances, autopsies are increasingly incorporating molecular analyses. But these new techniques also generate new questions. We might find a genetic mutation, but understanding its full penetrance, its interaction with other genes, or its environmental modifiers, even in death, is incredibly complex. The field of molecular autopsy, where post-mortem genetic testing helps explain conditions like sudden unexplained death, is rapidly evolving, with findings in journals like Genetics and Medicine still raising more questions than answers about the full picture of genetic predisposition. Even with the advent of virtual autopsies using advanced imaging like CT and MRI, these techniques have limitations. They are excellent for skeletal trauma or large organ pathologies, but they cannot replace the microscopic examination of tissue. They might miss subtle infections, early cancers, or specific cellular changes that are only visible under a microscope. The debate on the utility and limitations of virtual autopsies is ongoing in forensic and diagnostic radiology journals. Ultimately, autopsies are powerful tools. They teach us immense amounts about human health and disease. But they are also a stark reminder of the limits of our knowledge. Each solved mystery often uncovers several new ones. The pursuit of understanding through the study of the deceased is a continuous journey, filled with profound insights, but also with persistent, humbling questions about the vast, complex, and often elusive nature of life and death itself. So how much of a person's unique life history, their environment, their stress, and their choices truly influences their ultimate pathology, and how much of that can an autopsy ever really capture? If we can't definitively determine the true cause of death in every case, What does that mean for our understanding of medical certainty? And as technology advances, will we ever reach a point where every aspect of death is explainable, or will the human body always retain its profound final mysteries?